Okay, thank you. That was a really interesting, interesting talk. Okay, so we'll have our panel discussion now. Okay, so if anybody has any questions, they can come up to their microphone and ask.
Hello. Good morning. I was wondering what's the best way to treat patients with severe hyponatremia in cirrhotic patients. I have patients that their sodium getting less than even 120. And some of them are on diuretics, so I was wondering what's the best approach to bring their sodium up a little bit.
Okay, I will ask Dr. Wong if she can comment on that question, the treatment of severe hyponatremia, including patients with a sodium level less than 120.
First of all, thank you. Can you hear me?
Yes.
First of all, you need to figure out why the patient has hyponatremia. If the patient is diabetic, I usually check the blood sugar to make sure that it is not too high, that's causing fictitious hyponatremia. Secondly, I check whether the patient is on diuretics. And if so, I will stop the diuretics. The hyponatremia is related to excess vasopressin activity causing free water retention, and therefore in order to turn off the vasopressin, you need to actually refill the intravascular volume, and therefore I frequently give patients some albumin, perhaps about 50 to 75 grams at a time, and slowly watch the serum sodium rise. And in patients whose serum sodium is less than 125, I will recommend fluid restriction. And as you know, fluid restriction is actually not very effective. This is because you have to achieve a negative water balance. And these patients are usually excreting under 1 liter of urine a day. And therefore, it is difficult to recommend a fluid restriction of under 1 liter per day. However, I'll encourage them not to overdrink to worsen the hyponatremia.
Okay, thank you very much. Go ahead.
Is that caffeinated?
Yes, it's the caffeine.
Thank you.
No sweetener.
Yes.
Okay, while we're waiting for other questions, for Dr. Wong, I have an additional question for you. One of the areas of uncertainty is regarding TIPS contraindications in terms of whether there is an age where you would be hesitant to do an elective TIPS, and also degree of encephalopathy if it's controlled with 1 medication versus 2 medications. Do you have any comment on patients where you would be uninclined to perform an elective TIPS?
My rule of thumb is if they are over about 67, 68, I don't put a TIPS in. This is because the spontaneous encephalopathy after TIPS, the risks are too high. This is only my personal preference, and that is immediately after TIPS, I put them on lactulose in order to prevent the development of encephalopathy. I usually just use lactulose alone, but if lactulose is ineffective, then I'll add in rifaximin. With respect to the other contraindications, if a patient has had spontaneous encephalopathy in the previous 6 months, if the patient has cardiac disease, and patients with pulmonary hypertension, I tend not to put it in. If there is a biliary obstruction, I also don't put a TIPS in.
Okay, thank you very much. Okay, we'll start with the first, we'll start with Amandeep.
The question is regarding multiple organ transplants. We struggle to evaluate patients with cardiac ascites, whether the ascites is coming from heart or liver, and the protein is something we go by. But still, it could be challenging to see what the ascites protein is. So any guidance you can give how to work up these challenging cases where we are being asked to evaluate liver in chronic congestion, whether that patient will benefit from a heart transplant and a liver transplant?
If you believe that the liver issues are related to cardiac issues, usually we just do a heart transplant without doing a liver transplant. This is because once you relieve the upstream obstruction, the liver usually improves.
So liver biopsy to rule out the stage of congestion and fibrosis is what I was going into, that will benefit to understand that this patient can benefit only from a heart transplant or need a liver and a heart combined.
We've actually never done combined liver and heart together. I have had patients who have liver cirrhosis, cardiac cirrhosis as a result of cardiac problems, and all we have done is just a heart transplant and then watch the patient carefully post heart transplant. Because once you relieve the pressure, it is likely that the liver fibrosis will regress.
Any comments from the Cedars team? Because that's a common ask.
Yes. Yeah, I can also comment on that as well. We do some heart and liver transplants. We do use the biopsy as the primary determinant of whether the patient should be listed for a combined heart and liver transplant. If they have clear stage 4, and I know that there are studies showing that in the setting of hepatic congestion, even the fibrosis staging may not be fully reliable, but that's kind of how we go by. We've had one experience where we had a patient who is read as stage 3 fibrosis, and so we only listed the patient for a heart transplant alone. And then that patient ultimately decompensated, developed severe liver decompensation, and died because we couldn't list them and get them transplanted for a liver transplant in time. So long story short is we do tend to use a liver biopsy. It's transjugular. We measure the portal pressures for whatever that's worth. But yeah, if they have stage 4 fibrosis, then we list for combined heart and liver.
Thanks.
It's interesting how practices are different across the border. My transplant unit will not do the two together.
Interesting, yeah.
Yes.
Okay, go ahead.
For Dr. Ayoub and others, and that is investigational drugs on the way for NASH. There are a ton of them. Do you want to sort of maybe summarize in broad categories or where you think stage 2, stage 3 trials are?
That's a lot to handle. We can have a whole conversation afterward and go on. There are a lot of promising medications. Obeticholic acid was the one that we thought might be approved, but did not get approved in the past year. Some of the PPAR agonists have shown potential, so those are ones that are possible, but there's a wide variety of medications, many of which are beneficial, showing potential. I can go through, it would take a while to go through it.
Yeah, we'll cover that when the next time we invite you back for a lecture. Okay, go ahead.
Hello, I'm Kayvon Dolache, a GI and liver pathologist down here in Orange County. I was wondering for alcoholic and non-alcoholic fatty liver disease, what's your clinical parameters you look for when you do a liver biopsy?
To try and differentiate. Clinically, we always ask people how many alcoholic beverages they take in a week. If they're having any more than, say, 2 alcoholic beverages 3 times a week, then we highly consider alcohol as the etiology of their steatosis. And then we always recommend that they just stop all alcohol for a while before we try to biopsy them. Now, if we look at their labs and say we see low platelets or their imaging shows concern for cirrhosis, we may do a biopsy then to try to better stage the degree of their liver disease. But if they're coming in and it's just, we notice steatosis and abnormal LFTs, and there is the alcohol use, we first just try to stop the alcohol use before doing a biopsy. We've really tried to limit the amount of biopsies we do. And I think with MREs now being widely available, we tend to use that more, as well as FibroScans, which can be quickly done in the office. That helps us stage the fatty liver disease a lot.
Thank you. And also keep in mind that NASH and alcoholic liver disease are not mutually exclusive, which is why there's going to be a change in nomenclature to metabolic dysfunction associated fatty liver disease, because non-alcoholic doesn't mean that the patient is not drinking. Okay. I have a couple of questions for Walid. The two questions. Number one, you mentioned the SP100 and GP210 antibodies for AMA negative PBC. The question there, are those available commercially to order? Second question is with regards to IgG4 sclerosing cholangitis screening in your PSC, suspected PSC patients, if you implement that.
Sure. So for the first question, the two antibodies I mentioned, they are available commercially, but you have to look for the lab. There's a lab in Utah that does them, and Quest actually recently added them, according to what I heard. So they are available, but you have to make a couple of phone calls to get them. For the IgG4, I usually check for it, for two reasons. One, to make sure the patient has IgG4 cholangiopathy, not PSC. And the second one, once we know if a patient has PSC and we know they have an IgG4 positivity, these are the patients who actually need to watch more frequently because they progress to cirrhosis quite rapidly compared to people who don't have the IgG4. Now, some clues to help us looking for IgG4 cholangiopathy, the type of strictures the patient has. In PSC, you tend to have a shorter stricture, while in IgG4, for example, you have longer stricture. You look for other manifestation of IgG4. IgG4 affects the epithelial cell. So this patient has other extrahepatic manifestation, usually dry saliva, some salivary stone history. They have some lung disease that are common, pancreatitis, retroperitoneal fibrosis. So I usually look at the whole picture when I look at the patient with PSC. Looking at the films myself, if available for a patient with PSC, as an abdominal CT or MRI is quite helpful, because you'll be surprised how many times, for example, retroperitoneal fibrosis is missed, and you have to call the radiologist and ask him specifically about it. So, it's under-recognized, and I think it's going to gain more attention as we move on in the management for patients with biliary stricture.
Thank you. Okay, for Dr. Au, my question is with regards to exercise, I think we all agree it's very important. The problem is, as I've noticed in most of my fatty liver patients, and that's regardless of age, the exercise that they tend to cling to is walking, and they really love that 10,000 steps. What is your opinion on that? Should we tell them, okay, that's a start, or should we tell them that's not good enough?
Well, I hate to discourage people. So for those who really didn't do anything before and are now up to 10,000 steps, I always try to applaud their progress and say, great job, you're doing something. But I always try to get them to do more because it really isn't quite enough. So then I say, well, now that you're walking, what if we try speed walking or try jogging, take it to the next level, and don't overwhelm them, say maybe while you're out there walking for your 30 minutes, added 5 minutes where you're speed walking or jogging, and try to make it something that they can feel like that, okay, I can do this. This is easy enough. So that, because if you overwhelm them, I think a lot of times they'll just say, okay, forget it. I'm not even going to try. So doing something more manageable as a sort of exercise regimen is a great.
The other thing that I find helpful, exercising by yourself is quite boring. So you need to get them to exercise with someone else. And they usually, I've seen more enthusiasm to exercise more if they have a partner to help them exercise with. It works for both people, co-encouragement.
And there's that accountability too. If you have a friend who say, I'm going to go out with you and we're going to exercise together, you're less likely to not do it, which I think is a good thing.
Dr. Wong, since you're a master clinician, any other comments you have regarding advice to get your patients to exercise? I think you're muted still.
Mute.
Unmute yourself. Okay, well. Yeah, I know. I'm sure it was very, very insightful what you had to say. Okay. Okay, go ahead.
Anyone knows what's the update on the alpha pump?
Sure. Dr. Wong, if you can unmute yourself, and the question is regarding the alpha pump.
Okay, so alpha pump is the device that transports ascites from the parietal cavity and discharges it into the bladder. Currently, it's not approved in North America. There is a clinical trial that's going on in North America, and patients can, and I'm not sure exactly how many centers in the US are involved with the clinical trial, but I understand that the enrollment is going to finish in a month or so. And they're hoping that in a year they'll finish the study and then go to FDA for approval.
Thank you. And for those of you who are interested, Cedars-Sinai is one of the sites for the Alpha Pump trial. Feel free to just contact me directly. I am the site PI. Okay, do we have any other questions?
Does it work?
I'm sorry?
As you are the PI, so what's your take on it?
Oh, okay. So we have not done any implantations yet. That is because of the fact that we need someone who comes from Europe to be able to teach our radiologists. The plan is that we're going to start our implantations in July, which is when we have the scheduled site visit. But Florence, what is your opinion? Because I know you're one of the sites, one of the PIs as well.
I probably am the one in North America that has the most experience. In the carefully selected patients, it actually works very well. Instantly after you put it in, the patient goes home with a flat abdomen, and I don't have to worry so much about the salt restriction. When they have dietary indiscretions and eat more salt, I just turn up the pump rate. So they all love it.
Thank you. Go ahead.
Are they be given albumin with this patient with alpha pump? Because a lot of ascites nose getting drained, and do they need albumin?
Do they need albumin alongside the alpha pump since they are urinating out the excess fluid?
The inclusion criteria of the trial currently states that patients cannot have significant renal dysfunction, and the fluid is being pumped out somewhere between 500 mils to a liter a day, and it's being pumped out over the course of 16 hours. So the paracentesis rate is very slow, and so the liver surprisingly can compensate, and I don't have too many patients who are dependent on albumin infusions. The occasional one with some renal dysfunction, I do bring them in perhaps once a month for about 50 grams of albumin.
Okay, thank you.
Good morning. I have two questions. The first one is, you said that in the select or appropriate patient. So what is the, either one of you could answer this. You just mentioned renal function, but what other patient, cirrhotic, would be the ideal patient for this pump?
You mean for the pump or for tips?
For the alpha pump.
For the alpha pump.
Yeah, patients cannot have recurrent urinary tract infections. Patients cannot have too many episodes of SBP in the past, because after all, you're putting in a device, a foreign body. And I like to put it in patients who are not too cachectic. Otherwise, the pump itself can erode through the skin. For male patients, they cannot have bladder outlet obstruction. Because if you imagine you add a liter of fluid into the bladder a day, and if they can't pee, then they're in trouble.
Thank you. I'd also like to add that I think that in general, it's ideal for patients who are not TIPS candidates. If they are a TIPS candidate, TIPS also has the benefit of relieving portal pressure. So it has these extra benefits beyond just relieving the ascites. So my preference would be to TIPS them if they're appropriate for it, but there are certainly a good number of patients who are not appropriate for TIPS, in which case this may be a good alternative.
Thank you. And then my second question.
Sorry, I tend to put them in the elderly patients, people who are in their 70s. The oldest patient I put it in is an 82-year-old woman. And instantly getting rid of the ascites means that her center of gravity is no longer leaning forward and she's now falling a lot less.
Thank you.
I'm sorry, is there time for one
Yeah,
more?
please,
Okay,
please.
yeah. Just a quick question in terms of COVID and obesity and NASH and NAFLD this last 2020. Are there any studies that have happened over the past year that sort of kind of give us an incidence of how much weight Americans have gained, and has there been a significant rise in patients who've been diagnosed with NASH or NAFLD? Every time I see a patient now in person after the year of COVID, an average of 10, 15, 20-pound weight gain. So I was just curious.
Yeah, I'll leave that to the entire group since I'm personally not familiar with statistics on NASH over the last. I don't know what that is. Someone does not
I'm
like the question.
personally
I don't
not
know.
right. I'm personally not familiar with any statistics on that, but I think we can all say that we've all seen a lot of weight gain, increase in fatty liver, but I don't have any hard numbers.
It's not in the medical journal. From the Wall Street Journal, I think it was mentioned that average American gained about 15 to 20 pounds since COVID started. The other point I'd like to make, for those of you who are going to be prescribing weight loss drugs, what I learned from my endocrinologist is if you prescribe the medicine under diabetes code, it tends to be covered and tend to be less expensive than if you prescribe it under obesity. So just one way to get the patient access to these medications.
Yeah, I'll speak for myself. I'm personally not prescribing these weight loss medicines. It's just honestly just due to a lack of familiarity. But I do think that as hepatologists, we need to start incorporating that into our practice. At Cedars-Sinai, we also have an obesity center, which includes medical and surgical management. So I've been referring them there. But yeah, I think we should start to. Yes.
Yeah.
Mm-hmm. Yeah. Anybody else have anything to add?
I took the obesity medicine boards, and I think doing that whole course and having that extra education was very helpful, making me more familiar with it. And I also spent some time shadowing one of our local obesity specialists. So I think that's how I got a little more comfortable, because otherwise I don't think I would touch them either.
Okay, we have time for about one or two more questions if anybody has. No? Okay, I guess we will end this. Oh, go ahead, please. Yeah. Yeah, say that again?
When is the next meeting?
Yes, we have the next meeting in the Montage. I hope all of you will be there. That's going to be a very liver-focused meeting. I want to thank all the audience for their time, and I really want to thank my speakers, especially Dr. Wong, who joined us from Canada, and everybody have a great day.
Thank you.
Thank you.
Thank you, Vinay. Very good presentation. So we have texted.
Oh, yes.
That's me.
Oh, it's so nice to meet you.